Good morning. I'm Tom Strauss. It's my pleasure to introduce my friend and colleague Scott Irwin to you this morning. Scott is one of a small group of psychiatrists in the United States who has dedicated his career to the care of patients coping with cancer. Scott is currently the director of the Cedars-Sinai Comprehensive Cancer Center's Patient and Family Support Program, and also is a professor of psychiatry and behavioral neurosciences within the Cedars-Sinai Health System. Scott earned his Bachelor of Science degree from the University of California, Los Angeles, and then both an MD and a PhD in neuroscience at the University of Illinois, Urbana-Champaign. He completed his psychiatry residency at UC San Diego, and then did a 2-year elective in hospice and palliative care at the San Diego Hospice and the Institute for Palliative Medicine associated with it. He's a diplomate of the American Board of Psychiatry and Neurology, and also has subspecialty certification in psychosomatic medicine. Scott's scholarly work has been original and creative. Before most of our field was paying attention to the antidepressant properties of ketamine, for example, Scott completed an open-label pilot trial of oral ketamine for end-of-life depression in cancer patients while leading a palliative psychiatry program at the San Diego Hospice. Currently, Scott is a recipient of a large NCI R01 grant to examine the impact of virtual reality intervention on GI cancer pain. Scott has published widely and has been recognized at many levels for his research, teaching, consulting, and clinical work, and has received research funding from the NCI, NIMH, the National Palliative Care Research Center, the Archstone Foundation, and from industry. Please join me this morning in welcoming Dr. Scott Irwin. Thanks.
Thank you, Video Tom. It was good to see you and glad we were able to chat recently, although you can't hear me. And thank you, Dr. Cruz, for inviting me to give this talk today. So we're going to talk about the intersection of CL psychiatry and palliative care. And I don't have any relevant disclosures, but I do, I'm employed, thankfully, and have some consulting and royalties and research funding, et cetera. So just a little bit about my journey. I grew up in Chicago, and then I made my way to UCLA, as Tom mentioned. And for those of you, many of you might recognize this. Usually there's a separation between the medical campus and the undergraduate campus, but this is the inverted fountain in front of Franz Hall, which is where psychology at least was housed a long time ago, probably still is. And I spent many hours in the C floor, the third floor of the basement, starting my research career. And then I was able to move up to the 8th floor, working for Dr. Stan Shine, who I still think putters around UCLA. He was on the 8th floor and had an ocean view, which was much better. But he helped me launch my career, convinced me to do a PhD. And I'm thankful for that because it's that training that really served as the foundation for my career. So Stan, if you're out there, thank you. And if he's not out there, if any of you know him, please tell him I said hello. So here we are. And then I went to the cornfields of Illinois, as Tom mentioned, for my PhD and MD training, then to beautiful UC San Diego for residency training. And during my 7 years at San Diego Hospice, was closely affiliated with UCSD, which was right across the street. And often my grants were through UCSD, and we had all the residents come through, et cetera. And then about 6 years ago, I came back to Los Angeles to take this position at Cedars. So we're going to talk about palliative care and palliative care psychiatry. Those of you, it's hard not knowing who the audience is. Maybe some of my palliative care colleagues from UCLA are there, and certainly I know my psychiatry colleagues are there as well. But just as a review, palliative care is a specialized medical care for people with serious illness. The focus is on providing relief from symptoms, pain, and stress, whatever the diagnosis. The goal is to improve quality of life for both patient and family. And it's provided by a team of doctors, nurses, and other specialists who provide and work with the patient's other doctors to provide the extra layer of support. It's not an instead of. And it's appropriate at any age and any stage of a serious illness, and it can be provided together with curative treatment, or at the end of life, it may become the sole focus of care and be provided within hospice. So this is the model. If you're looking at the y-axis, that's what we're focused on in care, and the bottom axis is time. People present with an acute illness, and they want to modify or get rid of that illness. Sometimes these illnesses and a lot of illnesses become chronic. And then in this country, we define advanced disease as 6 months, although the field sort of loosens that up to a year before death. And during that time, there's life closure, last hours of life and dying, and then the bereavement care afterwards. And palliative care is therapies to relieve suffering and improve quality of life. And it can start right at acute illness, and it may be needed more or less over time and become the sole focus of care at end of life or hospice. So do we have diverging fields here? You know, when medicine started, we had medicine, and then we started specializing, and there became psychiatric care, and then CL psychiatry, and out of through that, psycho-oncology. Similarly, we had cancer care, and out of cancer care came hospice care. Dame Cicely Saunders wanting to care for people who were dying of cancer, which at that time was most of them. And then out of that came palliative care, because people realized the care in hospice was so good and patients often did better or lived longer. Well, why aren't we moving this upstream? I think of it as converging fields, in that the overlap in cancer, at least, of palliative care and psycho-oncology, or palliative care and CL with the other subspecialties, is what I've coined as palliative care psychiatry. So how are they similar? Well, both provide whole person care. We help manage the disease, not as much as our medicine colleagues. There's certainly physical symptoms that we attend to as part of psychiatric care and certainly as part of palliative care. Both fields address psychological issues, social issues, spiritual issues, practical issues like, how am I going to get my kids to school? How am I going to pay for this? What the end of life looks like and how we're going to manage that. Less of us in psychiatry get into this, but it still happens, especially for those of you working in ICUs. And then there's the loss and grief, not only in the family, but also the patients themselves as they lose what they had planned for the future and grieve over that. And of course, this is a complicated web that all impacts each other. To me, this is a full assessment of a patient. Both target patient concerns. And so if you look at patients that are considering death with dignity in Oregon, their biggest concern is loss of autonomy, followed by less participation in what they enjoy, a loss of dignity, which I'll return to, losing control of bodily functions goes down to 50%, being a burden on others, and concern of inadequate pain control. So out of these 6, only 2 are really in the physical realm. But we know in the hospital, the first thing we do when we walk into patients' room is we check on their vitals and their pain, and do they have a bowel movement? And we don't typically ask these questions about our patients that are in these situations. And then we address factors that affect a sense of dignity, and dignity means worthiness or worth, proper, fitting. And that's what people want, is care that they're worthy of as a human being. And so if you ask patients with advanced cancer, what impacts your dignity the most? Not being treated with respect or concern, feeling like a burden, feeling a lack of control, feeling like life was meaningless or that they left no lasting impression, bodily functions, and not feeling worthwhile or valued. So again, hospitals very focused on this one thing out of the things that are most important to patients with advanced illness. We have both similar outcomes in palliative care psychiatry and palliative care. they're more effective than usual care alone in reducing patient and family suffering, improving quality of care, enhancing symptom control, lessening feelings of disrespect, and for the administrators out there, cost less than standard care alone. And actually both prolong life as opposed to hasten death, which palliative care early on was sort of thought that's what happened when you went to hospice was, of course it costs less because we're not providing as much care, but that's not the case. Patients actually do better and live longer. And if you look at literature from psycho-oncology, patients tolerate and benefit from active cancer therapies more easily. Their emotional burden is eased, helps survivors with their psychological and social issues that occur. And when I moved from hospice to cancer care, it was amazing to me the impact on day-to-day life having cancer treatment is, even for those that are going to do well, of the time and the effort and the financial burden that it takes. And again, it costs less than standard care alone and improves mortality. So palliative care and we in CL Psychiatry working in these areas, we focus on the same areas: cancer, neurologic disorders, not as much diabetes, but certainly that's a concern for us prescribing psychiatric medications, heart disease, everybody struggling with how we live our lives. And of course, there's mental health and substance abuse, which is a big part of all of these things. And both tend to those who are affected, we're all members of families, whether we like them or not, or they're functional or not. And somebody becomes a patient. And as we know from group psychodynamics, every time you change a group, you go through those dynamics again. So there's a change in the family dynamics. And if that person then dies, there's another change in the family dynamic. And who better to help manage those group dynamics than people in psychiatry? We both provide care across the continuum. So you have emergency care all the way through hospice care. There's less psychiatry in hospice care, much less, a little bit in long-term care, and of course, a lot in the hospital settings. And of course, this is where we in CL Psychiatry make our bread and butter. And psycho-oncology is the small piece of this that focuses on cancer specialty care. And then palliative care also spans that same spectrum. And so this overlap is what I'm describing as palliative care psychiatry. Of course, as I mentioned, I'm now focused on cancer, but started my first 7 years in a large palliative care setting. I should say a little about San Diego Hospice. It was one of the largest and oldest hospices in the country in San Diego. At our height, we had about 1,000 patients a day on census around San Diego County. We had the editor of the Premier Journal, who was also the head of the specialty board, person who started the academy. We had the largest palliative care fellowship in the country, an international fellowship, and over 5,000 trainees a year that came through for various lengths of time to come. And as I said, when I went there after my residency, the psychiatry residents started coming through for a required rotation as well. Both align with the new healthcare goals. We're all familiar with this. And I honestly think palliative care and psychiatry will now rise to the top where the neurosurgeons and cardiologists are as we move towards value-based care. The biggest cost drivers in medicine are really end-of-life and psychiatric issues. So this is the triple aim, of course, of increased access and better quality, better outcomes and satisfaction, and lower costs. And the value piece is the quality over the cost. So we both target these cost drivers, which are the list of things that we said that we get involved in: heart disease, cancer, COPD, and overutilization of services. We often, as CL psychiatrists, get called because the patients are coming in twice, 3, 4 times as much as others, or their lengths of stay are longer and they don't know how to manage the patient's issues, either psychiatric or social, to move them to the next level of care. And there's evidence that people with one chronic medical condition have twice the rate of psychiatric disorders. And if you have more than 4 chronic medical conditions, and I really like interactive talk. So at this point, I'd say, how many of you have most of the patients on your panel with 4 or more chronic medical conditions? And I'm guessing 75% of you would raise your hand. 5 times higher rate of psychiatric disorders in these patients. So both should be integrated. The psychiatrists in the audience, maybe it's all psychiatrists, or mental health professionals, I should say, know about collaborative care, but we know that integrating psychiatric and medical care increases value, quality, lessens symptoms, people function better, they have a quality higher of life, they're more satisfied, and there is a reduced cost in long-term care admissions, readmissions, ED visits, ICU admissions, lengths of stay, all sorts of healthcare utilization. And I'll refer you to a set of papers we wrote by Brent Mossbach that sort of went through this, and also the impact on psychiatric and psychology visits on cost in cancer care. So we know that it works in specialty care as well and helps improve medical, mental health, financial satisfaction, and functional outcomes in cancer patients, in coronary artery disease, and we know many others, but this is where the evidence is for the most part. So what's the current reality? Well, same story as when I started, although better. We tend to work in silos. In some of the standalone cancer centers, and I won't name them, but their names I'm sure you're all familiar with. It's interesting to me that palliative care and psychiatry barely talk to each other and are like ships passing in the night, which certainly happens at Cedars, and I'm guessing at UCLA too. And then of course, sometimes the tensions of getting involved in the same issue because you're both consulted without any sort of organization or discussion. We're variable staff, and that leads to differing priorities or abilities of what we can address. And of course, we both have major workforce shortages. Whenever I'm asked about, why it takes me so long to find a psychiatrist to join us, I'm like, well, there's a shortage of psychiatrists, and most of them don't want to work in medical settings with medically ill patients. So, there's not a big pool, and palliative care is growing, but has very similar issues. So I wanted to switch to what are some of the specific psychiatric issues in palliative care. I am not palliative care boarded. I could have grandfathered in, but since I had, general psych and CL psych, I didn't want to pay for a third board and take a third test, and that's all changing. But I've really been an expert psychiatric consultant in palliative care or cancer settings, as opposed to what I would say doing primary palliative care, although some of those things I am able to do. In fact, I have a patient this week where the primary doctor is uncomfortable with having the goals of care conversation for a patient who really may be at the point of giving up the aggressive care that he's getting and living more comfortably. And I'm going to lead that conversation. Typically, the palliative care docs lead that conversation. So these are all the common things that you see in the hospital. Agitation can be a big one. I work 99% in the outpatient setting, so don't see this too much. Although saw a patient this year that had undiagnosed schizophrenia, and she was catatonic when she came into the cancer center. A lot of caregiver stress that our systems are just starting to think about and address. In advanced illness, a desire for hastened death, which is, in my opinion, not the same as suicide, which is driven by mental health issue. And of course, delirium is a big one, but we see any DSM diagnosis. We just see them. So if you take bipolar disorder and schizophrenia as an example, well, that's 1% of the world, and they have poor access to healthcare. So less than 1% of my panel are going to be patients with these issues. Of course, in the main hospital where a lot of you do your work, that's going to be much more, probably especially because of the lack of social determinants of health that these people have access to. So they end up at the EDs and the hospitals because of those issues, as you well know. Interestingly, most patients in palliative care settings had no previous psychiatric issues, but they become depressed or despondent or anxious or have insomnia. And then the things we do to them, like delirium as well. This was surprising to me. You would think it would sort of mirror or be more than what the population incidence and prevalences are, but it's not. So why do we need psychiatrists in the palliative care setting for advanced illness? Well, these diagnoses are sometimes hard to recognize and are often ignored. Well, of course they're depressed, they're dying. Or is this normal coping? Or is this a major depression? Is this demoralization? And if it is, does it meet criteria for major depression? Or is it really that they're just really struggling with their existential issues of closing this chapter in their life? These differential diagnoses are complicated, especially when it comes to delirium and some of the neuropsychiatric issues, brain cancer, really challenging. The patient recently where it's really hard to know whether she has lung cancer with some brain metastases, but those are all well controlled, but she has this bizarre neuropsychiatric symptoms, and I think we're missing a Parkinson's plus disease that's coincidental. It takes people with our training to figure that out. A lot of clinicians forget about all the non-pharmacologic interventions we have at our fingertips. And of course, there's varying degrees of comfortableness with prescribing just antidepressants all the way up to some of the other things we might use, especially those off-label like stimulants for depression. And of course, when you're dealing with specialists, they're not the primary care docs that are used to prescribing antidepressants all the time. So we can really help out in that area as well. So I want to turn to some specialized techniques that we have, just a little smattering. One is goals of care, which really drives everything. So what are their initial goals? So first diagnosis cancer, it's get rid of the cancer. Cancer doesn't go away or comes back. Then what is the goal? And the goals can change even if the context hasn't. So what are the goals after a diagnosis is given as well? Do you want a diagnostic workup, or would you rather just treat the symptoms? We don't have to do diagnostic workups. We don't have to do interventions. Patients have the right to refuse medical interventions if they have the capacity to make those decisions. And then what about the goal after we do all of that? If we do it, are we going to try to reverse what's going on? Are we going to just focus on symptoms? Or is this something that's irreversible and our only choice is to palliate these symptoms? Also, what's the context of the patient? How advanced is their underlying illness? What's their trajectory going to be? How debilitated are they? Prognosis, as I just mentioned. And we can be a lot better about prognosis than we think, than people say. And what I often coach patients about who want to know their prognosis, and this is harder in cancer now in the last 5 years, but there was 30 years where, well, hopefully a clinical trial will come out and really not much did. But there's still a frame. What's the worst case scenario? What's the best case scenario? How does it compare to the risk of driving here on the 101 or the 405? And then what does the literature say as far as 5-year survival? And we know that's a bell curve. And then you as my oncologist, out of the hundreds or thousands of patients you've seen like me, what do you think? And I tell them, nobody has a crystal ball. We're going to do everything we can to put you at the positive end of the bell curve. But that way I find patients have a framework of what to expect and make sure those that may have a shorter time are actually planning and not having false hope of having something more and not doing the work that they want to do before something bad happens. This is a big one, rapid titration of medications. So I learned this in hospice and from pain medication treatment. So we schedule medications based on their half-lives, or we're supposed to. You don't often, sometimes you don't see this happening, but really, right, it's 5 half-lives to steady state, 3 gets you most of the way, and you just prescribe the medication on the half-life to keep a steady state. However, the time to the concentration max in the blood is based on route, and we're talking about first pass metabolism medications. Like I said, metabolism dependent down here, but most medications are first pass metabolism. So the time to Cmax, parenterally is 15 to 30 minutes, and the time orally is an hour. So when we give Ativan Q4 to 6, we've left them for 3 to 5 hours at a point where it's not going to work, because if it hasn't worked at the Cmax, it's not going to work at Cmax plus 5 minutes. So I typically will prescribe my PRNs, and actually I have some examples later. I'll hold off until that comes up. But this is how we can prescribe PRN medication based on the time to Cmax. So, and there they are. So haloperidol, 1 milligram PLQ, 1 hour PRN agitation. Like I said, oral takes an hour to reach Cmax. It's not working by then. It's not going to work in an hour and 5. If 3 doses effective, not effective, call MD. I learned this the hard way when I was just out of training by not putting this there. But if 3 doses are not effective, then I have the wrong diagnosis, I have the wrong medication, or I have the wrong dose, and I need to be back involved. Haloperidol, you can give 100 milligrams in 24 hours. So when we're giving half a milligram, 2 milligrams, it's not that much. Now, we all know as psychiatrists what we need to look for and be careful about. And then you can take today's PRNs. If they needed 3 PRNs today, you can then add it to the scheduled dose if you're giving the Haldol once a day, and then continue the same PRN schedule. And it gets you to a point where you know the scheduled dose you need, and hopefully they're just using very occasional PRNs. And you could do the same thing with chlorpromazine, which we used a lot in hospice care. So for depression, of course, there's psychotherapies. We know group therapies reduces stress and mood symptoms in cancer patients. There's existential group therapy focused on value and meaning, and dignity therapy as well. Psychostimulants have a rapid effect in hours to days, really minimal adverse events, and don't seem to increase intolerance. You can titrate to effect or side effect. I just said that. There's actually some diminished opioid-induced sedation, and they may provide adjuvant analgesia. So I'll often start with 5 milligrams when they wake up and 5 milligrams 4 hours later. And then if I'm inpatient, I'll double that the next day and keep going up until I have my effect or I get a side effect. I have found that over 20 milligrams twice a day, it just doesn't seem to work. It just means it doesn't work for them. More lately, I've been using the longer acting psychostimulants. And I find that a lot of patients, they get that crash at 4 p.m. And I've been giving them a second dose of the long acting, and that gets them to bedtime, and they sleep and they do well. So that's something to consider. What about ketamine? Tom mentioned that I started this. So at San Diego Hospice, we use ketamine all the time for pain. There's a big literature in the 80s about ketamine for cancer pain. And so when the depression literature started coming out in the early 2000s, I said, well, why don't we try it for depression? And we did. But are all probably familiar with the studies of IV single infusions, and then now multiple infusions, and some clinics now doing infusion followed by IM or oral. It can be given oral, transdermally, parenterally, and now we have Spravato intranasally. There's other studies that do 0.1 to 0.5 milligrams per kilogram. It's commonly used anesthetic, as you know, and I just mentioned could answer in cancer pain. In my studies, I found that it helps with anxiety more than depression, which makes sense because it's a sedative and why they use it in anesthesia. And so my work, I give it orally. I start at 0.5 mg per kg. I increase it if there's no effect by 20%, up to 5 or 6 times. If there is an effect and it wanes, I increase it by 20% and usually get it back. If after 5 times of increasing it, there's no effect, I assume they're one of the 30% that it doesn't help. And then I move on to other things. I find fewer side effects with oral. It may, clinically, I see it work just as rapidly, or at least within 24 hours. My studies were very small and in very challenging patients in hospice, so the data didn't separate until a few weeks. So I think I just went through all of this. Of course, we don't know the long-term impact or effects of giving this. I do have a patient in San Diego who I couldn't get anyone to take over when I moved up here. So he's been on it for 8 years. We've tried taking him off and he becomes suicidal again. A very high functioning dentist, very well known in his field, and just had this desire to hang himself from his deck and was depressed, was a cancer patient, and the ketamine just made it all go away, and it still does to this day. And when I tell patients about this long-term impact, I say, you know, I mention it and they say, I'd rather live less long than and feel better than feel like this. So for anxiety, we have our complementary therapies, guided imagery. Often, if I have time in groups, I'll do a 3-minute guided imagery in a group like yourselves. I haven't tried it over a webinar, I don't think. I take that back, I have. And you can teach patients to do this themselves within 3 minutes. But muscle relaxation, hypnosis, which we've lost a focus on, but has a lot of medical evidence behind it. Exercise, of course, bright light, avoiding caffeine and alcohol, treating insomnia. I find treating insomnia in my career, that's the #1 thing, no matter what patients are dealing with. Everything gets a little bit better if you're sleeping. So sample orders, similarly for anxiety, you can give 0.25 milligrams orally every 60 minutes. And you can give up to 40 milligrams a day. I mean, I never really give more than 2, but the point is you're well within your safety margin. And if 3 doses, call us. So, you know, maybe I'm giving them Ativan on the half-life 0.5 3 times a day, but they're having breakthrough anxiety. I'll give them the PRNs of 0.25, figure out how much they're taking total in 24 hours and schedule that. Typically, I use Ativan more for just breakthrough. If I'm going to give it 3 times a day, I use a longer acting like clonazepam and do this and then use the Ativan as the PRN. And then you can convert the lorazepam to clonazepam at a 1 to 1/4 dose. And there's lots of benzo calculators, as I'm sure you all know. Some alternatives I learned in palliative care and in geriatric is that gabapentin, as you probably all know, can make people a little sleepy. Well, it can also help their anxiety quite a bit. And so if I need to stay away from benzos in the medically ill or older, I'll use gabapentin PRN. I've used trazodone PRN. You all know about buspirone, that it works really well, but not for very many people. And I put this up here as a reminder that opioids are not treatments for anxiety and can cause delirium and really should be reserved for pain. You know, this is more when I'm talking to palliative care groups, and same thing with atypical antipsychotics. When we see 25 milligrams for sleep or for anxiety, we know that that's just expensive Benadryl with more side effects, and we don't want the anticholinergic effects anyway. So not recommended for anxiety. Other topics to consider are what diagnostic modifications do we need? So depression, all of my patients have a lack of appetite when they're on chemotherapy. They all have reduced energy. So, you really got to focus on the emotional symptoms, the depression, the anhedonia, the feelings of helplessness, hopelessness, worthlessness, guilt, desire for hastened death. Like I said, desire for hastened death does not necessarily mean suicidal ideation or suicidal intent, but it certainly, when someone brings it up, it is until proven otherwise when I talk to them. Prognostication, we talked about. How do you break bad news to patients? And I talked to you a little bit about how I coach patients to ask their oncologists for what is the news, whether it's bad or not, but more, how do you tell the truth? Patients want to know the truth. Patients often know the truth without you telling them. And there's no evidence that telling the truth makes them depressed or worse. However, there's a whole sort of protocol for how you go about doing this. And the first thing is asking patients what they want to know. So in San Diego, I saw a lot of patients from Qualcomm, and they wanted to know every single thing down to the third decimal point. But I've also had patients that say, you know what, I'm living today like I have tomorrow, and one day I won't. That's all I need to know. So really figuring out what the patients want to know, and then how to get them that information. How do you resolve conflicts when there's conflict between family, or I quite often see conflicts between the patient and the family. A small example of that is mothers fly in to stay for months with their sons, and the sons are really grateful, but boy, they want some days to themselves, and they don't know how to tell their mothers, Mom, I'm glad you're here, but I really need some space. Or people get cancer and their friends want to do everything for them, but they don't want to feel like a cancer patient, or they want to do things on their own. So we talk about how to manage that and how to talk to their friends and how to tell their friends how to ask them what they need. Capacity for medical decision-making and research. And of course, this is bread and butter of CL psychiatry. And then drug-drug interactions, of course, is a big one, as well as the neuropsychiatric sequelae of medical treatments. Benzos, we talked about steroids, the cancer medications, all of those kinds of things. So for more knowledge, there is a clinical manual of palliative care psychiatry, was written by a few people I know, and was meant to be a very practical guide of how to do things. So some of the stuff I flashed on the screen, like the rapid titration of medications, it's sort of, if it fit one of those guides, medical students could put in their pocket and carry around with them. It's too big for that, but it wasn't meant to sort of cover the academic scholarly research, but how to do this when you're on the floor. So I'll leave you with, what experience do we want for our patients and families, our loved ones, and really ultimately for ourselves, because one day we will all be in this position. And Hippocrates, I think this is a fairly recent quote: cure sometimes, treat often, and comfort always. And I think we get very focused on cure, of which, other than infectious diseases and broken bones, we don't have a lot of cures in medicine, if you think about it. Certainly not in psychiatry. So it's the comfort and the treatment that's important. And one of my favorite quotes: although the world is full of suffering, it's also full of the overcoming of it. Someone who probably knew a lot of suffering, but also overcame it and didn't project that. We do this by strengthening meaning, value, and dignity in our patients, and we do it through what I call, well, I call it transdisciplinary care, but there's literature around the types of care. There's multidisciplinary care, which I forbid my team to use. There's interdisciplinary care, which I'm okay with, but really what we're trying to become is a sum greater than, or a whole greater than sum of its parts. So with that, I've left a little more time than I expected, 20 minutes instead of 15 for questions. So I'm happy to answer questions or go into a little more detail about any of the things I discussed. So thank you all for listening.
Well, thank you, Dr. Irwin, for such an enlightening talk, and glad you could join us. One of the takeaways, I think, for myself, at least for this presentation, it really is that multiple aspects the talk about are about integration, right? And that there's really not a dichotomy between body and mind. That there's an interaction between the two. They certainly influence the two. And I was struck by the data or the evidence showing that people who receive palliative care not only subjectively are more satisfied with their care, but there's better outcomes in terms of symptoms and mortality. Can you talk a little bit about that, and potentially, are there kind of mechanisms identified as to why these patients are doing better? Do they adhere to treatments better? Are they taking better care of themselves?
Yeah, I think it's multimodal, and there is some data that has picked apart some of these studies to look at what's the ingredient, if you will. One study I saw that was really interesting to me a couple of years ago was just the number of touches that a patient gets. So phone calls, visits, things like that make them feel better. But the two main things, believe it or not, that really seem to help most are the crucial conversations about what the realities of the situations are and the possibilities, and addressing psychiatric issues as well. Of course, if someone has uncontrolled pain, these palliative care docs have a lot of expertise in that area and can help get that pain under control quickly to reduce suffering, and maybe the patient's not in the hospital as long. So there are a lot of ingredients, but those seem to be the main ones.
Great, thank you. One of your earlier slides showed the web of all these different domains that influence outcomes for patients, physical, psychological, social. So I'm wondering, perhaps maybe this would have been more relevant earlier on in the pandemic, but during COVID, when there were restrictions as far as how many people could visit the patient, family members, did you see an uptick in terms of patient anxieties being consulted more frequently in those settings?
Absolutely. Again, I don't do my work in the inpatient setting, but heard just horror stories about people dying alone and families not being there with their patients. I'm sure many of you experienced that. We found in the outpatient setting, the social workers couldn't get patients off the phone or off the video because they just wanted to talk more and process more. We've seen, many fewer no-shows and more patients coming to our support services. I think that's also the providers themselves. We are distressed, and so we're recognizing it more in our patients. But yes, it's definitely anxiety is much higher, and for some people it's a little bit, for some people it's moderate, and for some people I've seen it impact their treatment. They're too afraid to come in, or just the thought of getting radiation therapy where they might have been able to tolerate it before, that added level of anxiety, they can't imagine doing it even if they're not afraid to come into the hospital because of COVID.
And you also talked about the goals of care. So what happens when the goals of care of the patient and the providers are not meeting? And specifically, the question is regarding the need to evaluate capacity for those patients who refuse interventions. Are formal capacity evaluations done for all patients who refuse interventions? And if so, who performs them?
That's a good question. So, and I think there's two separate questions. One is when the goals are misaligned, that's when you have to get everybody in the same room talking. And usually, prior, you probably want the team to talk and then include the patient and the family, but it's just not creating those triangles and letting things get split. And as psychiatrists, we're all very good at that and very familiar with that. As far as capacity goes, so any physician can determine capacity. And again, this is, very common in CL psychiatry. My approach when I was doing inpatient was happy to come, but you need to come with me because I don't know the risk, benefits, and alternatives of what you're offering. And you need to talk the patient through that, and I can help you to determine if they understand them. So capacity to me is really, do they understand the risk, benefits, and alternatives? Do they understand the risks of one of those alternatives being no care at all? Can they repeat it to me flexibly? Is it stable over time? And is it not a coerced choice by those things? So Cedars, the inpatient psychiatry service really has pushed back capacity assessments on the primary hospital teams unless they need help. And then, of course, where we come in as psychiatrists is the question of, is there a mental illness or a mental issue that's clouding capacity or making it so that they don't have capacity? I believe in California, psychologists are also able to do capacity assessments. I think social workers are not, but I would have to go back and check because I forget that all of the time. I hope that answered all of the questions.
Thank you. So on a related question, has there been any research on cultural differences as far as more accepting of kind of a terminal diagnosis versus being more aggressive in terms of curative approaches? Do you know anything about, or have you read anything about cultural differences as far as those factors?
So are we talking about cultures of the patients or cultural differences within medicine?
Oh, interesting. So probably the question is regarding cultural differences of the patient, but perhaps you could also comment on different disciplines of medicine.
Yeah, I mean, I think we are seeing a cultural change as one, we're trying to figure out how we don't bankrupt our healthcare system, and we realize that these things are extremely important and that we need to do them. And I think also, the words hospice and palliative care weren't mentioned when I was in medical school. Now, most medical schools incorporate training. A lot of residencies incorporate training. The field is growing. A lot of most major hospitals have palliative care services. And so there's much more of a socialization and an acceptance and walking with the primary treating physicians. The culture of the patient question I always struggle with. And actually, I don't think you guys did this, but often when I think we're all asked to give talks, we have to also put in a cultural competency. And of course, there's generalizations. African Americans are afraid to come to the emergency room or afraid to have DNRs. Asian culture, sometimes the decisions are left to the firstborn son, or depression or anxiety comes out more as somatic symptoms. But I find that this approach to care is an individual approach to care. And so if you get to know the patient, then you understand how their culture impacts the decisions that they're making. Because we all interact with our cultures, our religions, our ethnicities, our home countries differently. And so I don't find that the generalizations help. I think they help me in the back of my mind to realize maybe I need to be a little more focused on that part of the assessment, but it all comes down to the individual, and all individuals are different, even within cultures, of how they're going to react to the same thing. So that's sort of how I think about it.
That makes sense. And it sounds like those generalizations you provided were outdated, misguided, nothing supported by evidence, but just that things that can come up in conversations, I guess even amongst providers. So we have a couple of questions actually regarding some non-traditional uses of psychiatric or psychoactive compounds. Specifically, what about the use of cannabis for anorexia or pain in palliative care? Can you comment on that?
Yeah, it's interesting. In San Diego, not very many patients were using CBD or THC, and actually Tom Strauss has written an excellent paper on this and gives an excellent talk on this as well. And there's certain ratios of CBD and THC that you need, and you need some of the THC to make the CBD work. But there's really only evidence for it in some muscle spasticity and one other thing that I'm blanking on. And then when I moved to LA, every cancer patient seemed to be taking it before it was legalized. I mean, it was medically legalized, but then even before it was just legal, and now that it's legal. And what I found is most patients don't find that it helps. There's some that do, and it can be various things: anxiety, insomnia, pain. And so mostly, if they're using it, my assessment is it helping and not hurting in any way? Like making you sit around your house like a couch potato, but that you're functioning better. If they're not using it, but they ask me about it, I tend to say, I think the tools that I have are better, and I know what the doses are and what I'm giving you and how to manipulate them. When you go get this stuff, you don't know what's in it. You don't know what the ratios are. And most of my patients really aren't that impressed with it.
No. So along that lines of inquiry, psychedelics. So that's certainly a hot topic these days. I think back in May, there were 2 New York Times articles on the front page. And we actually have a psychiatry resident psychedelic interest group here. Can you talk about the use of psilocybin, MDMA-assisted psychotherapies in the palliative care setting? I know studies have been done for some end-of-life patient population, but what about its use maybe even earlier on?
Yeah, there's a lot of interest in this based on the studies. And if you talk to some of the, I'm trying to think of a better word than older palliative care,
experience.
My mentors who were children of the 60s or lived through the 60s, when palliative care first took root again in hospice care in the US in the 70s, they found that these medications really did help for lots of things and still have an interest in using it. So my take on it is these studies have been fairly small. There's sort of equal amount of evidence that they can cause anxiety and depression as much as they help anxiety and depression. And they all have that intensive psychotherapy that's hours long. And the thought is, and of course, this was a thought back in the 60s, and the thought, with MDMA going on 20, 30 years now, and amphetamines, that it's a mechanism to get around patient defenses and help to sort of push them forward faster through psychotherapy. My issue is, how could we possibly implement that? You and I were talking before we started to talk about how it's so hard to use Spravato because of all of the restrictions around it. How are we going to have 6 to 8 hours of psychotherapy for hundreds or thousands of cancer patients? So right now, the data to me is small, it's mixed, and I just don't see how it practically would, be useful. The other thing I'll say is I get asked this question a lot because of my use of ketamine, and I use ketamine like it's Prozac or an SSRI or whatever. And quite often I don't see any dissociation. There's a debate with ketamine about whether you need that dissociation or a psychedelic effect to get the antidepressant effect. And Dr. Dunn, I know you do this, so I'd be interested in what your views have been on it. But certainly most of the patients, because I use it orally, don't get that dissociation. Some have had some bizarre effects, but I see the antidepressant effect even when they don't have the dissociation. Maybe they had it, but I didn't pick it up, or they didn't pick it up. But I don't think it's in the same category as the psychedelics.
Yeah, I would agree. Our experience is that with the ketamine, S-ketamine, that we still see antidepressant effects even without that dissociative quality. Interesting. We have a question about resources for it sounds like for the treatment team. So what resources are available, most helpful for members of the team at times that the team members seem to be emotionally, psychologically, or overwhelmed, by the patient, by what's going on, with the patient situation?
Yeah, I was just talking to my counterpart at City of Hope yesterday about this exact thing. And of course, physician wellness and staff wellness was a big issue before COVID, and now even more so with COVID. And I think we need to think about within our professional and work roles, and then in individual private roles. So as far as in work roles, as you all know as CL psychiatrists, which I'm again assuming that's most of the audience, that sometimes just us being there and us helping facilitate the conversations, and us helping as a staff reframe what's going on with patients, or their anxiety about the psychiatric stuff that we're going to help with, really calms things down. When there's bad outcomes, or when patients die, or something pretty tragic happens, I offer to do team debriefs, which often end up being sort of supportive group therapy, but try to keep it professional and also away from an M&M, not like what what do we do right? What do we do wrong? It's how did we impact this? I am a firm believer that for individual supportive help, that needs to be outside of the work relationship. And I've seen that go very badly when it hasn't, in terms of needing to report abuse or finding out somebody has addiction problems. You know, you're working side by side with these folks, and best not to get that. That's why we have EAP. We all have our own opinions about EAP. I think we could do something better personally, but there needs to be something outside of the system for that, in my opinion. We did a study at the hospice on nurses and if they used rituals, and it turned out that the patients, the nurses that used rituals, and one of the favorites I remember is a nurse, every time a patient would die, would look out an open window and sort of imagining this person going through the window and going to a different part of their existence. That people that have their own rituals tend to do better, but everyone has their own ritual. And so that's the other thing about, okay, let's have a supportive care support group for staff that are struggling. Well, everybody deals with these things in their own ways, and you're not picking like, okay, we're going to do CBT for anxiety for 8 sessions. It's how do you cope, and we all have our different ways of coping. So I think it's supporting staff to get the help they need, making sure they have access to the help they need on the personal side. But I think the palliative care docs and the CL psychiatrists that work in ICUs and stuff can definitely play a role in helping debrief some of these harder things when the staff is struggling.
Well, one of my most vivid memories in medical school was the relief of the primary teams when the CL service showed up. And like you said, just their presence was very anxiolytic. So, and one of the reasons I went into psychiatry.
Yeah, we all know that when there's a bunch of chaos upstairs, we know the patient has a personality disorder, right, in general. And it's going and helping the team calm down. That's the biggest intervention that we do.
Absolutely. We have one question about the role of psychiatrists on palliative teams. Do you see more psychiatrists being hired to work full-time on palliative teams, or are we going to be more of an ancillary service and used in consultation? Where do you think psychiatrists fit best?
Yeah, it's interesting because there are not really roles or jobs, although I've seen over time that palliative care teams are hiring or embedding psychiatrists or trying to get more involved. That's true at Pittsburgh, it's true down at UCSD. And to me, it's so when palliative care started, it had an identity crisis about how do we get the oncologists and the other docs to listen to us. And it's by showing up, being in rounds, understanding their language, what is top of their priority, how we can be helpful to them. And so for psychiatry, it's the same thing, the sort of consult by chart or sort of quick messages doesn't really work. It's actually being embedded and working together with the teams. How you convince a palliative care team to do that? Well, Bill Mitchell, who leads your palliative care team, trained with us at San Diego Hospice, and I actually forget, I might have been a resident when he was a fellow there, or I was an attending when he was a fellow. I don't recall if Bill's on, he can chime in, but so he's very sensitive to that. But I get that question all the time. The palliative care docs will say, we can never get psychiatry to show up, and psychiatry will say, we want to go play with palliative care, but they won't let us. And it's really getting together and finding out how you can be synergistic.
Great. Well, thank you so much for a wonderful talk and your thoughtful answers to our questions. Really appreciate you being here today. It's 12 o'clock, so we'll end today's grand rounds. And thank you everybody for your questions and for attending. And it looks like from our schedule, we'll be off for the next 4 weeks. So we'll see you sometime in October. Until then, take care.
Thank you all.
Bye.
Bye-bye.